This is Armugam Balasubramanian from Mindray India ultrasound team. We are very happy to meet you all again in this wonderful evening for Fetal Radiology Samrakshan mini series on FGR Part 2 conducted by KREST Kochi and IRIA Kochi. Mindray India proudly welcome Dr. Rijo Matthew, Dr. Bavagaran, Dr. Gulab, and all the delegates who signed in through Zoom and YouTube. Welcome all. Let's begin this webinar by tech talk from an industry expert. Let's welcome Mr. Punarvasu Vyas, the National Application Manager of Mindray India ultrasound team, who is going to present an advanced technology in ultrasound market. Over to you, Mr. Punarvasu Vyas. Thanks.
Thank you, Arumugam, for the wonderful introduction, and I'd like to thank all the organizers for Samrakshan, to all the speakers, Dr. Bhavaran, Dr. Gulab, and Dr. Rijo, for giving us the opportunity to be able to be a part of this such a wonderful event. And I wish we all stay safe in this time of crisis. I just want to talk about a small topic today. I mean, it's a small talk, but the scope is very deep, and I want to talk about fetal heart in a little bit detail, and more importantly, how artificial intelligence has started playing a big role in fetal heart analysis. So why is fetal heart important? We all know that congenital heart diseases and congenital heart malformations, they are the second most important common incident. They're the most important incident of problems. According to the ISWAG guidelines, we need to actually measure the 6 particular planes, which is 4-chamber view, the left ventricular outflow tract, the right ventricular outflow tract, the 3VT view, the stomach, and the ductal arch. Getting this manually is also very easy for industry experts, but if the machine is more accurate, if the machine is able to, help you diagnose these things easily and quickly and save a lot of time for you, and if the machine is accurate, then why not depend on a machine? Because now we've started depending on a lot of machines also. So first we used to, memorize the way where if we wanted to travel, if we used to memorize the way where we need to go. Now we have Google Maps, AI-based things, which is helping us in a better way. So similarly, Smart Planes Fetal Heart or Smart Planes FH is a very new technology. And this is this is a clinical paper on the importance of fetal heart screening status. We are all aware of it. If anyone needs to view it, you can please ask me. I can share the paper with you. I will put my... Yes, Smart Planes FH. So I can share the details with you. Now what we conventionally do is either do it manually or we do it with something called a stick. Now Smart Planes FH has taken this even one level above stick. What we do is we've made it completely automatic. So what is happening is in a conventional way, all we need to do is in fetal heart is we just take a 4-chamber view of the heart and we turn on fetal Smart Planes FH and take a fetal heart scan, and the machine automatically gives you the thing. So what we need to do is, this is what you get actually automatically with the click of one single button. You don't need to do a lot of, so all you need to get, you get the 4-chamber view, you get the LVOT, you get the RVOT, you get the ductal arch, and you get the 3-vessel chamber also. So all 6 planes that you need are available, and the beautiful part is it is fully automatic. You don't need to do any fiduciary tags. You don't need to apply a lot of time, and all you need to have is a good 4-chamber view to begin with, and you're done basically. The machine does it automatically. It is based on deep learning AI with more than 8,000 plus cases done on patients, and that is how it is. So steps are very easy. Step 1 is acquire a 3D fetal heart data set from a 4-chamber view. Press the Smart Planes FH button on the touch panel. press the navigate button, and then move the trackball to the crux, and then press just click, and the machine will automatically give you. So there's a small video we'd like to play. So this is how it's acquired, and then we take this, put it on the crux, press the button, and automatically all the views are generated. So this is how quick it is. Even before I can stop talking, it has already done the measurement. So this is how easy it is, easy to calculate, easy to um, give you all the views required, and very, very, very effective. So what are the smart planes benefit? Basically, it increases your confidence. It greatly improves the fetal heart acquiring rate. Many a times, many planes are manually not possible to reach. But if you do it with the help of 4D and 3D, actually what you're doing is acquiring the entire volume. So it enhances your diagnostic confidence of a fetal heart study. More importantly, since it's intelligent, it minimizes scanning time, and it improves the clinical efficiency also, and reduces operator dependence. So intra-operator and inter-operator variations become very less. And then again, it is very, very accurate because we've done 8,000 patients. Um, 8,000 patients have been done by industry experts to get the data set possible. And 8,000 patients means lakhs and lakhs of images basically for the fetal heart anatomy. So this is accurate, and this is fetal heart smart planes for you. In short, a very big technology, a very helpful technology for all of us, and I hope it helps us improve. Any question, please put it in the comments box. We'll be more than happy to answer these questions. And over to Dr. Rijo, please. Thank you very much for your time, sir.
So thank you, Punarvasu, for that technical presentation. So good evening and warm welcome to each one of you who have joined the part 2 of the mini series of fetal growth restriction, the Fetal Radiology Samrakshan webinar series organized by KREST Kochi and IRIA Kochi. So this is the second part of the mini series on fetal growth restriction. The Samrakshan, this is part of the Samrakshan project of Indian Radiological and Imaging Association that was launched in 2019. Samrakshan is a project aiming to reduce the perinatal mortality in India. The two major causes of perinatal deaths in India are prematurity and birth-related complications. So India, as I've already mentioned in the previous sessions, has 25% of perinatal deaths all over the world. So we have to address perinatal mortality in a two-pronged strategy that Samrakshan has devised, and that is first trimester screening for preeclampsia and fetal growth restriction, and the third trimester screening for fetal growth restriction and the proper management to time the delivery. So with that intention in mind, Samrakshan has devised certain processes, that is Samrakshan encourages the skill enhancement of the radiologists and all the stakeholders in the larger context of maternal, fetal and neonatal medicine. At the same time, it also has got with the offline and online education portals and channels, it tries to increase the skill enhancement of a radiologist and their understanding about the fetal growth restriction and preeclampsia. At the same time, we have got the research orientation. We encourages our practitioners to submit forms, the first trimester and second trimester forms with relation to preeclampsia and fetal growth restriction, and a strong research-based, a pan-India research base from different parts of the states involving the many districts of the country are also being a part of this project. We have already received and analyzed the data from 25 districts from 12 states in our country. These data are being continuously analyzed and being published online in a very transparent manner in the Journal of Fetal Radiology, a journal to which Samrakshan is closely related to. So in the last session, we had two talks, one by Dr. Lalit Kishore Sharma on wrong dates, incorrect growth assessment, and fetal deaths, break the loop. So we have emphasized that it is high time that we cannot keep changing the expected date of delivery in every pregnancy scans that you do. If you got a previous scan that was done between 8 and 14 weeks of pregnancy, and there is an expected date of delivery recorded there, you have to follow that as the corrected EDD. And because your percentile calculations of the growth and the Doppler percentile calculations in the third trimester has to be based on that corrected EDD. Then the second session talk in the last session was by Dr. Bavaharan, who explained the pathophysiological mechanism of fetal growth restriction, the how and why of a growth restricted fetus. What happens to a growth restricted fetus in a hypoxic environment? What all mechanisms happen in different vessels in the placental and the fetal units, and the subsequent Doppler changes, and what adaptation the baby undergoes, and what are the mechanisms of acidosis that sets in. So this is what was explained in a very simple manner. Bauharan has done that job of explaining a lot of complicated things. And I have seen a lot of questions on the last session that was primarily based on the logical sequences of the hemodynamic sequences in the different vessels, especially the uterine vessels, umbilical vessels, the middle cerebral, the ductus venosus, and the umbilical vein. So in the second part of this session, we will have Dr. Bavaharan again coming to you. We'll be talking on the second part of the fetal growth restriction, that is the criteria for stage-based management in fetal growth restriction. Before that, I have to introduce a young radiologist from Pali, Rajasthan. That is, Pali is near Jodhpur. This is Samrakshan encourages young radiologists and postgraduates to be part of this process. We want them to talk on the fetal radiology, the role of radiology and imaging in the larger context of maternal, fetal, and neonatal medicine. It is high time they have to speak for their profession, their specialty. So we have identified some of the young good speakers in the IRIA UR, that is a segment that Indian Radiological and Imaging Association has started nurturing the UR radiologists, the young radiologists, and we are providing platforms for them to speak on their subjects in a very passionate manner. So we have identified Dr. Gulab Chaja, who did his post-graduation from Madras Medical College and has settled in Pali in Rajasthan, has got an excellent practice there. He is well versed with his subject, very dedicated and passionate, and he will be talking to us on the fetal Dopplers, how to measure it, and what are the common pitfalls that you come across. Because there were a lot of questions in the last session on the common pitfalls or whatever problems that the practitioners encounter while they were doing Dopplers, because the basic understanding of Doppler is necessary. Basic understanding of the hemodynamic processes of fetal growth restriction is necessary. Without these two things, we cannot go further beyond into the next session that Dr. Bavaharan will be talking to us on the stage-based criteria for stage-based management and the timing of delivery. So with that introduction, may I invite Dr. Gulab Chaja to present the topic fetal Dopplers, how to measure, and what are the common pitfalls. Over to you, Dr. Chaja.
Sir, shall I share my screen now?
Yeah, you have to share your screen. Yeah, please.
1 second. Just 1 second, sir. Sir, are you able to see the screen now?
Yeah. We can please make it into slideshow mode.
Yeah. And am I audible, sir?
Yeah, you're audible.
So thank you, Dr. Rijo sir, Dr. Bavaharan sir, and the entire Samrakshan team for providing me this platform to present my inputs and my experience. So the first topic for today, which we'll be looking into, are the fetal Doppler studies pertaining to the fetal growth restriction. The focus will be entirely on the techniques and pitfalls. So coming to the overview of the topics which are going to look. So first we'll be looking at the Doppler techniques. How do we do it right? And among it, we'll be looking at the uterine arteries, the umbilical artery, the middle cerebrals, the aortic isthmus, the ductus venosus, the umbilical vein, and how to differentiate a normal from an abnormal waveform, the factors affecting the waveforms, and the various pitfalls. So it is very important to know that the first two vessels, the uterines and the umbilicals, actually represent the placenta. So they are the placental markers. The uterine artery travels towards the from the maternal side towards the placenta, and the umbilical artery travels from the fetal side towards the placenta. So they actually represents the placenta. The middle cerebral and the aortic isthmus actually represents the fetal artery. So they are the fetal arterial markers, and the ductus venosus and the umbilical vein represents the fetal veins. So they are the fetal venous markers. So this frame of mind is very important before proceeding and interpreting Dopplers. And then we have the cerebroplacental ratio, which are using very commonly. And by the word itself, it means that we are using one of the fetal arterial markers, that is the cerebro, that is the MCA, and another one is the placental marker, that is the umbilical artery. So the first and foremost steps in before doing any third trimester scan would be to accurately date a pregnancy, which has been elaborated in the last session beautifully by Dr. Lalit sir. And then we, after dating, after getting details of the previous scans or the LMP and putting into the putting this data into the system, then we go on to do the biometries and plot the charts and the percentiles. So before proceed to Doppler, this is what we have to look at. One is the percentile of the fetal weight, and another is the percentile of the abdominal circumference. Okay, why we do this? This will be explained. So coming to the Doppler indices, the one which is used is the PI index. The rest are all obsolete. Of course, you can do it, but the by and far the most accurate and most reliable is one is the PI, because it takes into account even the flows below the baseline, and the denominator is the mean velocity. So a bit of few words on the again the physiology of the uteroplacental and the fetoplacental circulation. So in a non-pregnant state, the uterine artery divides it into the arcuate, the radial, the basal, and finally the spiral arteries end in the endometrium. Okay, while in a pregnant state, the spiral arteries dilate due to the invasion of the trophoblast from the placental side. So what happens when this trophoblast invade, the spiral arteries dilate. So there is increase in the surface area, and hence there is development of the low resistance. So as the pregnancy advances, so there is development of low resistance within the placental unit. So that is why the fetus is able to get more blood from the maternal side. So coming to the fetoplacental unit. So now the blood from the maternal side has reached the placenta. Now there is oxygenation and exchange of nutrients happening at the placental surface. Now this oxygenated blood travels from the umbilical vein. It enters into the fetal abdomen. It goes along to the fetal liver. And here the 2/3 of the oxygenated blood goes into the portal sinus, and 1/3 of the flow actually goes into the ductus venosus. But this jet is important. So this flow actually directly bypasses the fetal liver, and this oxygenated blood is directly pushed into the IVC through a jet, where it hits the roof of the right atrium. Then through a mechanism, it actually through the angle, it actually enters into the foramen ovale, and through the left atrium, the left ventricle, the aorta, and finally it reaches into the brain through the brachiocephalic vessels. So thereby the oxygenated blood is actually diverted, bypassing the liver, and straight it reaches the brain and the myocardium through the coronary arteries. Now what happens to this deoxygenated blood which is coming from the IVC? So this blood travels to the right atrium, it mixes with the blood in the right atrium, it reaches the right ventricle through the pulmonary trunk. This mixed blood is actually entering the descending aorta. So there will be some amount of oxygenated blood which is entering the descending aorta, and some amount of mixed blood which is entering the descending thoracic aorta. Now through this aorta, this supplies the renal and the mesenteric vessels. So now most of the fetus is oxygenation is complete, and then the remaining amount of deoxygenated blood actually travels back through the internal iliac arteries to the umbilical arteries and finally to the placenta to get further more oxygenation. So this is how the cycle is actually complete. Now, coming to the Dopplers, the first part will be the placental markers. So part 1, part 2, and part 3. So the first artery which we'll be looking is the uterine artery. As we all know, it's a branch of the internal iliac artery. So we'll be looking at somewhere here, and it crosses the external iliac vessel. So coming to the technique, the patient is in a supine position. The transabdominally, you place the probe in the lower in the lower quadrant of the abdomen along the inguinal region, and it is angled medially. Now you switch on the color, you identify the uterine artery. Now this uterine artery actually crosses the external iliac vessel. So this is the external iliac artery. This is the external iliac vein in the blue. You will see one vessel which is crossing this two vessels. So this is the uterine artery. Now you place your sample gate exactly about 1 to 2 centimeters distal to this point of crossing. So this is very important because we'll avoid tracing from the external iliac vessels. Okay, so after this vessel crosses, so you place your sample gate somewhere here, and you make sure that the angles are of the angle of the Doppler inclination is kept less than 30 degrees or as close to 0 as possible. And by looking at the velocity, if the velocity of the vessel is more than 60 centimeters per second, they are typical of the uterine arteries, and it is useful point to differentiate from the arcuate arteries, which are a branch of the uterine arteries. So you obtain at least 3 to 5 consecutive good waveforms, good quality uniform waveforms. So that is very important. And then you apply auto PI tracing from the 3 or more than 3 good waveforms. And the same process is again repeated for the contralateral uterine artery. So you have got PI of right and the left. Then you calculate the mean PI and the percentile. You have multiple charts for that. So now what happens if sometimes uterine artery bifurcates before this intersection? So before this crossing over happens, then the sample volume should be placed on the artery where the artery actually just before the bifurcation of the uterine artery. So it is important that you place the calipers before the uterine artery bifurcates and not after it bifurcates. So with advancing age, this uterus goes into a kind of dextro rotation. So the left will not be so the left artery will not be run as lateral as the right. So you see the right will run more laterally and the left run more medially. So still it is difficult, then you partially fill the bladder and then repeat it. So these are the normal waveforms which we commonly see. This is in the first trimester, this is in the second, and this is in the third trimester. So we are pretty well versed with this. So in third trimester, you want to see a lot of diastolic flow going into the uterine artery so that the placental perfusion is complete. And when you start seeing the waveforms seen in first trimester in the third trimester, so these are abnormal and the PI indices are raised. So you calculate the PI index of the right, you calculate the PI index of the left, and you put it on these calculators. They will give you the mean and the percentile. Example, in this case, this mean PI percentile for this 30-week pregnancy is around 98 percentile. So it is pathological. So pitfalls of uterine artery, if you image the wrong artery, okay. So in this case, they have obtained this waveform thinking it to be a uterine artery, but we very well know that these are kind of sort of systemic arteries, which we commonly do while doing lower limb arteries. So what has happened, they have named the vessel as uterine and taken the PI values, which were erroneous. So this case was repeated again by another examiner where they have correctly identified the uterine artery and they were getting the normal waveforms. So correct selection of vessel is important. Sometimes in much advanced pregnancies, you can even mistakenly inseminate the umbilical arteries through the cord, which is actually pretty close to the insemination site. So next we'll be looking at the umbilical arteries. So umbilical artery we'll be imaging somewhere here. So umbilical arteries travel. So take the blood back from the fetus towards the placenta. So it's a placental marker. Coming to the technique, you take a free loop of the cord, you put the color box on and you make it longer. Okay, you make it longer than it is wider. Okay, the blood flow has to be homogeneously filling, the red and blue. You should be able to differentiate. There should be no overlapping of subsequent vessels adjacent. So you have to focus your sample gate only on one vessel, and that has to be adequate sample gate which actually covers the most of the lumen of the umbilical artery. And then you get at least 3 to 5 uniform good waveforms. And you can reduce the scale to see the spectrum better. As in this case, we have seen these waveforms are uniform and there is a good diastolic flow. The percentile also falls within normal limits. Now coming to the site where you want to take the waveforms. So ISWAG completely recommends free loop of the cord because of the concept that the resistance is actually highest at the abdominal cord insertion, that is at the fetal end, and it is lowest at the placental end. So as you go towards the placenta, the resistance decreases. So we want to take an average of these two measurements. We don't want to fall too low and we don't want to fall too high. So we take free loop. However, the American SMFM guidelines recommend abdominal cord insertion just to make it more reproducible. This is the abdominal cord site. Now, regardless of the site chosen, you are free to choose. Regardless of site choose, consistency in the site means you have seen a patient today, you have interrogated the umbilical, you have investigated the fetal end. The next time also you actually take the readings at the fetal end. So that is important. Now coming to the abnormal patterns. So normal pattern, there is a lot of diastolic flow. In abnormal patterns, you see this diastolic flow is reducing, and there is reduced in diastolic flow. The percentile falls more than 90th percentiles. This is abnormal. Now there is more developing placental resistance, then there is absent end diastolic flow. Furthermore, increase in the placental resistance, there is actually reverse end diastolic flow. So these are abnormal. Now pitfalls of umbilical artery. Now if you start getting waveforms like this, okay, you start getting waveforms like this, and then you start looking at the fetal chest, whether there are fetal movements. So usually the causes for this irregular waveforms, where the one peak is high, one peak is low, sort of irregular waveforms, is usually due to fetal breathing, which can be checked at the chest or the face level by putting the Dopplers. And you have to ask the patient to wait and come back till you get waveforms like this. So again, a pitfall of umbilical artery, if you image sort of two umbilical arteries which are lying close by, two loops which are actually lying close by, and if you put a sample gate along both the vessels, okay, so you will get patterns like this, okay, where there are double peaks, and you can actually mistake it for even arrhythmias. So if the vessel direction is towards the same side, now imagine if it is opposite side, okay, two loops lying where the flow is lying opposite, so you will see two peaks on either side of the baseline. So that is due to wrong placement of the calipers adjacent to two vessels. So you have to make sure that you place it within one vessel, only one umbilical artery. Then if you see patterns like this, there are absent spectrum at some places. So these are usually due to hiccups. Now, factors affecting the waveform, there are a lot of factors which affect the waveforms. By and large, the most important for us, which we can actually monitor, are the fetal breathing and the site of measurement. So fetal breathing has to be minimum. You have to obtain the measurements in a state of fetal apnea. The site, we have already explained, it is the free loop. So next, come to the fetal arterial markers. So they are the MCA and the aortic isthmus. So MCA, one of the easiest vessel to image. Okay, you just have to take the axial section of the level of the head, which we do for the BPD. You come down, include the thalami and the sphenoid wings, identify the circle of Willis. Okay, then you have to insonate at this proximal third, just close to the ICA origin. The Doppler gate has to be adequate to ensure most of the vessel has been taken. Now angles are important in MCA. So angle has to be kept close to 0 degrees. Okay. Very important, because we want to measure PSV in MCA, and other arteries we are not bothered about the PSV, we are bothered only about the indices. So angle is kept to close to 0 degrees, so you get accurate measurements of the PSV, and at least 3 to 10 waveforms have to be good, uniform have to obtain, and auto PI tracing is applied from the uniform waveforms. So this is normal and this is abnormal. Now in normal, you get a small amount of diastolic flow happening in the diastole. So the PI indices are raised. It means that the fetal cerebral circulation is a high resistance circulation, unlike to the adult fetal circulation, which is a low resistance pattern. Now when you start getting low resistance pattern in a fetus, so that is pathological. Okay, these are the kind of vessels pattern you see in the adults. So the PI has fallen to 0.8 and it is less than 5th percentile. So this is abnormal. Now PSV of MCA is important. because it is used directly to as a non-invasive tool for detecting fetal anemia. So any MCA PSV greater than 1.5 moms. So you have these charts in calculators on the internet. You just have to put the gestational age and you have to put the PSV value. So it will tell you whether it is less than 1.5 or more than 1.5. So that's a good indicator to start intrauterine blood transfusion. There are a lot of factors which can actually influence your tracings by a lot of factors, behavior, movements, breathings, contractions, but the by and large what you can control is the measurements. The rest all is not in, it's not in your hands. So for example, let's take this case. Okay, here here this scan is being done with no pressure over the with no increased transducer pressure. Okay, so you can see that the PI is around 1.2. Now this has been done with increased transducer pressure. So see how the PI has shooten up. So it become 1.6. Now imagine a case where you have a fetal brain sparing and already you are getting a low resistance pattern. You apply transducer pressure and you get a reading and you get a reading with high PI. So you start to interpret that this reading is normal, but that is not the case. So you have to apply the minimum or no pressure at all while doing MCA Dopplers. Very important to avoid the false negatives. Then, so now you know the umbilical artery value. Now you know the MCA value. So you can put it on the charts. So put the weeks, MCA, umbilical artery, this will calculate the CPRs. So in this case of this 33 weeks, the CPR is abnormal, falling less than first percentile. Now CPR actually directly represents the interaction between the fetus and the placenta. So this is cerebro and this is placental. Now fetus, if it is abnormal, it's an indirect indicator of a fetal brain sparing effect. So this is most useful in late onset IUGR, which we'll be seeing the next talk. Okay, now regardless of the birth weight, if you find an abnormal CPR at term, it directly indicates perinatal and neonatal morbidity. Okay, it indicates neonatal morbidity. So the second vessel which is going to image after the MCA is the aortic isthmus. So where is this aortic isthmus located? So this is seen between the origin of the left subclavian artery and the connection of the ductus to the aorta. So this area. So this is the area which you want to image while doing while doing aortic isthmus Doppler. So this was already explained, this physiology. Now this is the aortic arch. This is the ductal arch. Okay, oxygenated blood travels from the aortic arch and it directed towards the brain. In the ductal arch, it is actually the mixed blood is traveling towards the descending aorta. Now this is the portion of the aortic isthmus. Now see if the fetal brain is asking for more oxygen, there is hypoxia, the fetal brain is asking for more oxygen. So this blood, which is actually was traveling towards the descending aorta, will now actually start to move towards the fetal brain. So this is what we want to image. We want to catch this point where there is reversal, of flow. Normally flow has to flow this direction. When there is flow towards the fetal brain, it means it is abnormal. So now you can actually do it either in longitudinal aortic arch view or even in a transverse 3 tracheal view, whichever is comfortable. But the accurate position of the cursor is possible in a longitudinal view because you can see this left subclavian coming out beautifully in this view. So you know by short that you are actually interrogating the aortic isthmus. But easier one to do in the third trimester is usually a 3VT view, and the results are pretty same. So coming to the normal waveform, these are the waveforms you get in aortic isthmus normally, where there is in the early part of the pregnancy where you get a good amount of diastolic flow. It is forward. It is always forward. It is always forward flow. Now, when you start entering the third trimester, you may see a small amount of reversal in the late systole, but still you can see that there is the predominant diastole is actually filled with forward flow, and it is not below the baseline. So this amount of reversal is acceptable in the late systole, but when you start receiving reversal of flow in the entire diastole, okay, you look at the entire diastole. If you start receiving this reversal of flow, then it is abnormal. As we have seen this case, this was a 35-week-old pregnancy, and the aortic isthmus showed abnormal signals where the reversal is actually persisting throughout the diastole. So this is abnormal. Now, what does aortic abnormal Doppler indicate? So even in a setting of even in a setting of normal DV Doppler in the early onset types, this abnormality is highly indicative of a very late neonatal neurological injury. So late neonatal neurological injury can be indicated by abnormal aortic ischemic Doppler. Next, we come to the fetal venous markers. So in this, we have the ductus venosus and the umbilical vein. So ductus venosus, the fabulous vessel. So now you see, we are going to image somewhere here. So this is the point we are going to interrogate. Now, why this is such a beautiful vessel? Because it's it actually takes away blood directly from the umbilical vein towards the heart, and it bypasses the liver. So it's a trumpet-shaped vessel, very narrow. It takes about 30% flow at 20 weeks and 20% flow at 30 weeks, but that is important. And it goes towards the heart. So it is directed towards the heart. So it's a marker of the right-sided atrium or the right-sided cardiac chambers. And this has a very clear role in the distribution of the highly oxygenated umbilical venous blood directly to the myocardium and to the brain. Now, I call this as the prognosticator. So that will be seen in the next talk. So coming to the technique, okay, the same technique is followed which we follow in the first trimester and the second trimester. So you take either a mid-sag or an transverse oblique plane through the fetal abdomen, whichever is comfortable and whichever is available to you at that point of time. So you put the switch on the color map, you narrow the color box down, you try to image the umbilical vein, the ductus, and the IVC in a single image. Okay, you magnify the image, you zoom it up. Now you start looking for the area of aliasing. So as the ductus venosus takes off from the umbilical vein, the velocities within the vessel shoots up. So there is an area of aliasing. Now the site which I have to examine is the isthmus, which is close to the umbilical vein end and not close to the IVC. Okay, the sample gate has to be small in case of ductus venosus to include only the venosus and not the adjacent vessels. The sweep speed, the sweep speed should be actually high to spread the waveform so that you can look at all the waves. So these are the three waves: the S, the D, and the A wave. S represents the early ventricular systole, the D represents the early ventricular diastole, and A wave represents the fetal atrial contraction. So now we are bothered only about this A wave. Why? Because in normal pregnancy, the flow is usually uniform and it is anti-grade. It is never below the baseline. Okay, now as the pressure in the right atrium builds, okay, now there is a lot of flow which is actually not being pushed by the heart. So as the right atrial pressure increases, this A wave decreases. So as the A wave decreases, the PI index shoots up. So PI more than 95th percentile is abnormal. Now there is more increased pressure within the right side of the heart. So there is a reversal of the A wave. Now when you start seeing this reversal, this is a very late finding and it is a sign of impending acidemia. So you can have some variabilities in this S and the D frames. That is usually due to breathing, but you have to wait for the fetus in a state of apnea. So this was a case we saw, this was the same case that of the aortic ischemic Doppler abnormality. So in this case, in the same case, we had this ductus venosus, which actually showed this absent A wave. So the A wave, actually there is absent A wave touching the baseline, but it is not below the baseline. So this is absent A wave abnormal. The percentiles are above the 95th percentile. And when the fetus further deteriorates, there is a reversal. So when you start seeing this patterns below the baseline, so this is highly abnormal and it is sign of late acidemia. So when you are imaging this region, okay, it is pretty easy to actually put the calipers on the wrong vessels. So now you need to know the patterns of those adjacent vessels. So IVC and hepatic veins actually usually have a same pattern. Now these both are same patterns, except for the fact that the direction of the blood flow is actually changed in this particular case. The IVC is actually towards the transducer and the left hepatic vein is actually away from the transducer. So you get this sort of reversal beyond the baseline in case of hepatic and the IVC. It is very important to know this, and so that you don't mistake these vessels for the ductus and misinterpret the findings. So as has happened in this case, they have examined the hepatic veins and they have seen this and they've called this ductus venous reversal. So till this we were knowing about the three waveforms. Now we have started looking into the fourth waveform, that is the V wave. So this is the late part of the systole where it represents the ventricular relaxation. Okay, but Fayan, the most important for us is still the A wave. This is more important in the importance of the cardiovascular status of the fetus. So where you can see this kind of M pattern happening, where there is abnormality in the late diastole and in the end systole. So this V wave is getting importance. So umbilical vein, again, this is used only when all the other parameters are abnormal. So the site is usually the intra-abdominal portion. Usually it is a non-pulsatile forward kind of flow. So you see this non-pulsatile forward flow always happening, or you can get this single kind of pulsations, which is usually due to breathing. Okay, so these are normal. Okay, when you start seeing double pulsating patterns, or even reversal and triple pulsating patterns in the setting of abnormal DV and other FGR features. So this means that you have very little time left, just hours, okay, not even days, just hours. So PI should not be calculated when the fetal body movements are active and when fetal breathing movements are very active. So this will interpret your, this will actually cause changes in your PI results. When there is fetal arrhythmias, fetal hiccups, when the traces are irregular. So the solution is you have to wait or make the patient walk so that you get more time and you start seeing the patient again till you get good waveforms. So the take home points from my side are, you need to learn the embryo anatomy better, the physiology of the fetal circulation. You have to sight the correct vessel. You have to zoom to the area of the interest. Okay, zoom, make your color box narrow. Okay, then adjust the sample gate and the vessel wall filter. So wall filter is reduced to so that diastolic flow is not missed. Okay, avoid overlapping with the adjacent vessels. You get good uniform waveforms. Then only you apply the PI indices. Angle of incination is important, in which you want to know the the PSV. Most important in case of MCA, where you want to detect fetal anemia, and in uterine arteries, where you want to make sure that you are looking at the uterines and not at the arcuates. Do not apply pressure. Do not apply pressure on the fetal head while doing an MCA Doppler. So Doppler is important in every obstetric scan, irrespective of the requisition, the charges of the time. The doctor has not requested it, you still do it. The patient doesn't pay you, you still do it. You don't have time, but still you have to do it. And practice will make you perfect. So you have to reach a point by doing more and more Dopplers, where just by looking at the color pulsations of the Doppler, you can actually start interpreting what is happening or what is happening at the spectral end. So you should know what you're going to expect. Okay, umbilical arteries pulsating in this pattern, I know that there is a reverse kind of flow happening. So your measurements has to be repeatable and reproducible within the acceptable limits, within the ranges, and your interpretations matter a lot. So you start saying now no to advising clinical correlation. Now you start correlating. Okay, thank you.
So thank you, Dr. Gulab, for that wonderful lecture. You have nicely explained the importance of the vessels to be examined in the background of fetal growth restriction. I must also thank Dr. Jivraj Singh, the Secretary of Rajasthan IRA, who had introduced me when I came there at Jaipur for the Samrakshan CME. So you are really a gem for Samrakshan. Thank you, Dr. Gulab. And meanwhile, I would like to emphasize a point that Samrakshan encourages to reduce the entry barriers or the levels for everyone to attempt and practice the Samrakshan protocol. We have started a mentoring program, and those of you, the youngsters who are interested to be part of it, can write to samrakshan@gmail.com. We will now go to the second session. That's a continuation of the fetal growth restriction talk that was already started and given by Dr. Bhavaharan Rajalingam, the National Academic Lead of Samrakshan Project of Indian Radiological and Imaging Association. He had already explained to us the pathophysiology of fetal growth restriction. Today, we are going into the culmination of this mini series of fetal growth restriction, that is the stage-based criteria and of the stage-based management of fetal growth restriction and the timing of delivery and the management related issues. Without much ado, I will invite Dr. Bhavaharan Rajalingam to present the topic.
Should I share, stop sharing my
you have
screen?
to stop. Yeah, you have to stop sharing. Then only Dr. Bavaran will be able to share his screen.
So good evening, one and all. So we'll continue with our talk, which we had, our discussion, which we had 2 days before. Right. We'll start from where we left. We'll have a revision of the previous one. So small for fetuses, ultrasound estimated fetal weight, or you have your abdominal circumference. Sorry. Okay. So either the estimated fetal weight or the abdominal circumference of less than 10 centile as criteria. So divided into SGA or FGR. So that's the basic classification we have. Now, this can be either SGA or FGR, but SGA, as you all know, has near normal perinatal outcome, whereas FGR is always pathological due to abnormal fetoplacental circulation and cause poor perinatal outcome. Now, the aim of us is by doing a Doppler is not only to deliver a live baby. We are planning to deliver a live, neurologically intact baby. So that's what we are aiming at. So FGR can be broadly classified by early onset, late onset by about 32 weeks. We explained the reason why 32 was considered for early and late yesterday. Less than 32 weeks fetuses usually have very good fetal adaptation. They are immature, but they are very, very good tolerance to hypoxia, and though they have severe placental disease, and they are always associated, most commonly associated with preeclampsia. Whereas more than 32 weeks late onset diseases have poor adaptation. They are mature, but very poor tolerance, have mild placental disease, and there is low association with PE. So this is the basic classification. But when the abdominal circumference and the estimated fetal weight falls below the third centile, it automatically classifies as FGR. This is because of abnormal neurological outcome. Now, let's get to this thing. Now, the timing of delivery, this is what is important. Now, the problem is we cannot deliver, saying that the weight is less or one Doppler parameter is abnormal. So I want to deliver, I'm afraid, because I may lose the baby, because you're risking a premature complications. At the same time, you cannot wait too long within the mother's womb to get this baby, because that will cause more of hypoxemia and more chances of neurological deficits and more chances of IUD. So you have to strike a balance. Now, this balance is achieved only with the help of your serial scans and Doppler when you have a diagnosed case of IUGR. So this is important. When you have a diagnosed case of IUGR, the management is based purely on your serial scans and your Doppler findings, because the CTG, that is the cardiac topography, becomes abnormal very late than compared to the Doppler changes. So clinically, to pick up an abnormality is much later than Doppler, because Doppler picks up much earlier. Let's say 2 to 3 weeks prior, it picks up the abnormality. So if we have 4 stages of FGR, it's only in the 3rd stage of FGR, the baby clinically, that is the CTG, becomes abnormal. So we have got, but what we have to do is by the 3rd stage, we'll have to deliver the fetus to have a neurologically intact fetus. So this is what is important. Now, timing of delivery is very important. Now, you cannot deliver it much earlier. As you all know, you cannot deliver it much later. So the risk of prematurity and the benefits of late delivery has to be always weighed. So that is where we come into play. Now, what happens, we already discussed. Just imagine what we have discussed before. We'll have few cases today for discussion, for practical orientation also today. We'll also have some polls for you to understand, and for me to see how many of you have got the points really, so that we could go on further. Now, when we have, as Gulab already has put it into 3 different things, the placental side, and you have the umbilical artery side. that is the placenta. The umbilical artery and the uterine artery contribute to the placenta. Now, the first stage is placenta getting damaged. So for the umbilical artery to become abnormal, the placenta has to be 50% damaged. We are clear about it. And in the first trimester, the uterine artery is abnormal because placentation is abnormal. Number one. Number two, now the baby senses there is an abnormality in the placenta. I am not getting enough oxygen. So it changes, it redistributes its arterial supply. So that is the second stage, that is arterial redistribution. Third thing is venous decompensation. Now the veins, what already discussed, that is the ductus venosus and the umbilical vein. Now these two gets reversed and abnormal. See, there are so many other vessels, the hepatic arteries there, the myocardial, the coronary artery dilatation, the E and F factor or the strain pattern of the myocardial vessels, are so many other things. But these are important, the uterine artery, the umbilical artery. When it is abnormal, the baby responds by diverting its arterial supply to the brain and the adrenals, as you all know. So this is arterial redistribution, where the blood from the aorta gets diverted back to the brain. So there is a reversal of flow in the aortic isthmus. In the middle cerebral artery, there is a increased diastolic component, so the PI falls. So this is brain sparing effect. Now, when this process goes on, after some time, there is deterioration. That deterioration is what you see, that is the decompensated state, is what you see in the venous Doppler. That is ductus venosus A wave reversal. Recently, yes, I've not discussed this V wave in the previous thing because we are still not very sure about the ventricular relaxation pattern, how far we are going to help, because we see a lot of variation in the patterns because of respiration. Let's take some time in a 6 months or 1 year down the line, we'll have more number of cases. Let's see how this variation comes through. So by now in the ductus venosus, or what are we concerned about is about the A wave. So the A wave cannot be below the baseline. That's what A wave should always be forward. A wave cannot be below the baseline. And the umbilical artery, umbilical vein showing pulsatility is abnormal. So this is what we are having. So again, a recap, we have the early onset, late onset. Early onset is less than 32, late onset is more than 32. This is what the deterioration, what we are talking about. See, you could see here, this is the placental disease. There is a compensated hypoxia because the middle cerebral artery PI falls. Decompensated hypoxia where the aortic isthmus increases, ductus venosus starts to show the abnormality, that is decrease in the A wave, and later there is a abnormal decrease or reversal of A wave. See here, only at the stage of decompensated hypoxia, the CTG becomes abnormal. So clinically, the baby becomes abnormal only at stage 3. Where are we picking up? We are picking up the problem of the abnormality much earlier than the cardiotocographic abnormality. This is what we'll have to understand. Now, there are certain things. Why prolonged jaundice is there? We picked up yesterday. Why the baby doesn't move much? Yes, baby doesn't move much because it tries to conserve energy. So the fetal kick count falls. The fetal movement decreases. Similarly, the postnatal jaundice. So everything has a reason why things happen. Now, this is what happens when there is a placental disease. So uterine artery is more than 95th percentile. CPR falls, then that is the stage, that is where the MCA PI CPR falls. Then the aortic PI, aortic isthmic PI increases, then aortic isthmus reversal, then happens the CTG deceleration and our ductus venosus reversal. So this is what the sequence of events that happen. Now, this is an important slide for us. You could see here, there are 4 different stages of IUGR. So 4 different stages. When you call it IUGR, as I told you, when the estimated fetal weight is less than 3rd percentile, it directly classifies as IUGR. When the estimated fetal weight is less than 10th centile, with Doppler abnormalities, either the uterine artery PI more than 95th percentile, CPR less than 5, MCA PI less than 5. Any of these 4 classifies this as stage 1. There has been reclassification of this. Let's not confuse this now. So this is stage 1. Stage 2 is resistance and redistribution, where aortic isthmus goes in for reversal. As you all know, the aortic isthmus should always have a forward flow. Stage 3, low suspicion, where A wave falls, that is, ductus venosus PI goes more than 95, but still A wave is above the baseline, or the umbilical artery shows reverse end diastolic flow. Fourth is high suspicion of acidosis and risk of death, that is reversal of A wave, you could see here. So these are the 4 different stages of IUGR. Now this stages is same for both less than 32 weeks and more than 32 weeks for any IUGR. But when you have an IUGR, you have to put into this. There was a question, do we have to include the 2D and Doppler finding? Yes, your 2D Doppler findings and 2D findings and Doppler findings is a culmination of all these 4 stages. So you'll have to put everything into the place and you have to give a diagnosis of stages. So this is the same slide which we had now. Let's take the other example. Now we have a 10th to 50th centile of estimated fetal weight. Now this is a very important classification. Now 10th to 50th centile, again, this is not IUGR, but it can have late onset FGRs. So you need to have proper surveillance. So these babies, uterine artery may be abnormal, CPR may be abnormal, and umbilical artery may be normal. As we discussed, in late onset FGRs, the umbilical arteries may be abnormal because the umbilical artery shows normality because the placental damage is much less, that is less than 30%. So CPR is the key. Whereas in early onset FGR, there's always a severe placental insufficiency and there is chronic fetal hypoxia. So the baby has chronic hypoxia and the baby has good adaptation. The umbilical artery is always abnormal and they may progress to decompensated hypoxia. So the management is always based on fetal adaptability. So it is important that you have fetal adaptability, how the fetus adapts to the abnormal circulation. Now, when you have stage 1, you can wait till 37 weeks. Why 37 weeks? Because after which there is not much growth that is happening within the mother's intrauterine cavity. So till 37 weeks, if it is stage 1, you can wait. And if it is more than 37 weeks, you can deliver by labor induction. Stage 2, you can wait till 34 weeks if there is stage 2. And if it is 34 weeks, you can deliver by LSCS. If it is less than 34 weeks, you can follow it up every 3 days. Stage 3, 30 weeks. If it is more than 30, deliver. Less than 30, daily follow. If it is stage 4, 26 to 27. So anything more than 27 weeks, you can deliver by LSCS because stage 4 is a stage where there's a high impending chance the baby can go in for an IUD. You have to take a chance to deliver this fetuses, or you'll have to go for a daily follow. So to recap, stage 1, you can wait till 37 weeks. Stage 2, you can wait till 34 weeks. Stage 3, you can wait till 30 weeks. Stage 4, you can wait till 27 weeks. Now, there is one more question. IUGR with oligoamnios. Now, IUGR with oligoamnios is a sequel. See, for example, the baby is not having enough blood flow. So the baby is not showing good flow to the kidneys. Kidney may become small and there can be decreased urine output. That leads to decreased fluid, that is amniotic fluid. So calculating this amniotic fluid is very important. See, amniotic fluid calculation can be done in 2 different things. One is by using a single vertical pocket, or the other one is a 4-quadrant. In singleton, I always prefer to use a 4-quadrant measurement. In multiple pregnancies, 2 or more, we generally use a single vertical pocket. Now, this quadrant, you divide the mother's abdomen into 4 and you actually keep your probe perpendicular to the mother's abdomen and you measure in 4 different quadrants. Now, measurement has to be very quick. It's very important. You cannot take a measurement, talk over phone, come back and then do your measurements. So it's when you take AFI, make sure you take all the 4 quadrant and measure, because this is variable. And when it is very low, for example, if it is somewhere around 7 to 8, and if you see the bladder completely distended, wait for some time, allow the bladder. Usually the fetal bladder empties every 20 to 25 minutes. So after about 15-20 minutes, call back the patient and reassess the AFI. You may get the right AFI. So this AFI is a sequel of IUGR. Now, since the AFI is low, it doesn't mean you'll have to deliver because it's a sequel. Some babies respond by putting out lesser urine. Some baby may respond by giving about moderate urine. Some fetus may not respond at all. So these are different types of babies which can respond differently to the mechanism. So this is important to know that the SGA has normal Dopplers, uterine artery notching. Again, I'm stressing we are not using the notching. We are not using notching because in the PI we calculate the notching. So do not report notching. So SGA with abnormal fetus is called FGRs. So the umbilical artery important. You need to measure the umbilical artery is important. The MCA is important. Now, as already pointed out, the CPR, that is the cerebroplacental ratio, it is nothing but how the baby responds, how the baby's brain responds to the placental disease. That is the ratio you're taking. That is CPR. How the baby's brain responds to the abnormal placental disease. So that indicates how well the baby has adapted itself. That is why CPR is very, very important. Now, there was a question like SD ratio. Yes, SD ratio in umbilical artery was used, but we always calculate the PI because PI has, again, a lot of advantages. It is more than one. Even below the baseline, it can be calculated. It is the average value. So you can actually take the MCI PI and your umbilical artery PI and always measure the differences. So the main goal in FGR is to identify small fetuses and you should divide it into FGR and SGA. So that is what we are looking at. So early and late onset is again 32 weeks. So clinically a single stage based protocol. So this protocol of stage 1, stage 2, stage 3, stage 4. Stage 1, you can wait till 37 weeks. Stage 2, you can wait till 34 weeks. Stage 3, you can wait till 30 weeks. Stage 4, 27 weeks. So this is what is the classification. Very simple. So stage 1, if it is less than 37 weeks, you need to follow it up weekly. Stage 2, if it is less than 34 weeks, you follow it up every 3 days. Stage 3, 4, if it is stage 3, if it is less than 30, stage 4, if it is less than 27, follow it up daily. This is very simple and very straightforward. This is what we are going to do. Why do we have to evaluate this IUGR critically is because perinatal mortality is high. Again, I told you, we have to deliver a live baby, number one. Number two, we have to deliver a neurologically intact baby. And there has been a lot of studies saying that hypoglycemia and polycythemia are high, and also cardiovascular diseases and diabetes is much common in cases of preterm or improperly managed fetuses. So our aim is to deliver a healthy baby, weigh the risks and benefits, where Doppler is very important in management. We need to interpret the Doppler. We need to step up in our shoes and we need to interpret the Doppler. So that is what is very important. Hi, can we have the poll now, please? Armugam?
Yes, sir. Shall I launch it now?
Yes. Now, the listeners, we'll have the polls. We'll have 10 different questions. Okay. Everything will have one choices. Now, you will have 5 minutes for answering, 3 minutes for answering all the 10 questions. What you have to do is just put the 10 questions answer. Then we'll discuss every case and we'll discuss three cases here for the next 15-20 minutes and we'll close off this session. So shall we start the polling now?
Already started, sir.
Yes, there are 10 questions. You can just go in and click the right answers in everything. We'll see the answers one by one. So the first question is first trimester, when will you reassign the EDD? This was Dr. Lalit's talk. In 14 to 20 weeks, when will you reassign the EDD? in 20 to 26 weeks, suppose if you have to, suppose a patient comes in for the first time, how will you reassign the EDD? Which is the best method to assign the EDD? Is it USG, LMP, or the combination of the above? Leave this fifth question, because that comes to one of the panel questions. So leave the fifth question. So sixth question, which is significant to suspect IUGR? Like a measurement, which is the best? 4-quadrant, single vertical pocket, or any of the above? IUGR, decrease in female length. Is that a marker of IUGR? Early onset FGR, which is false. Late onset FGR, IUGR, which is false. Right. So shall we get back? Shall we see the answers, Armugam?
Shall I end the polling, sir?
Yeah, you can end the polling. Yes. So
Bhavaharan, the poll was not visible for the YouTube.
no, sir,
Yes,
it will
sir.
not be visible in YouTube,
Not
sir.
seen in
It will be
YouTube.
visible only with people logging into Zoom.
Fine.
Yes.
Okay.
Yes.
Fine.
Right. So oh, there are a few answers for the fifth one also. Okay, fine. Right. Fine. Shall we get into the few cases? We'll have these questions one by one when we go through. Right. I have the answers. Poll with me. Armugam, let the poll answers be with me.
Okay,
So coming on to the second part, the practical application. Now we discussed about the practical application. We know what the pathophysiology is now. We are versed with certain vessels. What are the vessels? We are basic vessels. So there are other vessels. Don't get into high funda data now. Basic vessels: the umbilical artery, uterine artery, MCA, ductus venosus, your ductus umbilical vein, and the aortic isthmus. So these are the 6 vessels that you need to evaluate in everything. Now, measurement of age. So that is important. So 2 different things that we need to understand here. So we need to assign the fetal age, which was very well described by Dr. Lalit sir. Assign the fetal size. Now, what is fetal size and what is fetal growth? There are 2 different things. So fetal size is the weight of the fetus at that point of gestation. For example, I'm measuring a fetus at about 28 weeks and I'm getting a value. Let's say the baby weighs around 1.1 kg. Now, this is at 40th percentile, for example. For us, it is appropriate for age. We'll say, yes, the baby is fine. This is what the size of the baby is. But what is growth? When you go back to the baby's second trimester analysis or any scan done before, let's say after 20 to 28 weeks, you take that measurement and you compare that measurement with the present scan. The difference between these 2, that is the interval growth, is the growth pattern, that is the growth velocity or the fetal growth curve. Now, fetal size may be normal. For example, 28 weeks, it may be normal. But when you compare the size of the fetus at 24 weeks and compare this now, the baby would not have been at the potential. So the potential for the growth of the baby is not met. Hope you understand the potential. So I have a potential of doing, let's say, 10 cases a day, and I do only 4 cases a day. For me, it is low. For another person, doing 4 cases may be good for his thing. That is one stage. So that is what the growth potential or the growth velocity. So the failure to achieve growth potential is FGR. It is not the fetal size of that point. So that is why when you have a scan, let's say when the patient doesn't come to you to scan at all, suddenly patient lands at 25 weeks for the first scan and the date is completely incorrigible, you need to actually do two different scans at 25th week and 27 weeks to assign the fetal age and also to say, yes, this baby is growing appropriately for the gestational age. Similarly, when you have a scan at 24 weeks, compare always with 28 weeks to assess the growth potential. So that is called the potential. The failure to achieve the growth potential is called FGR. So fetal weight has to be estimated, and in all early onset FGR, you need to exclude anomalies. Amniotic fluid assessment is essential. Less than 28 weeks, always give single vertical pocket. More than 28 weeks, go for 4th quadrant. In case of twins, always take at any point of gestation, single vertical pocket. Color Doppler, biophysical profile. Now, next question was, first question of the poll was saying about the first trimester, when will you reassign the EDD? The answer was more than 7 days. 62% of you have given right. Yes, it is right, what you have said. In 14 to 20 weeks, when will you reassign the EDD? 7 to 10 days, 68%. Excellent. Dr. Lalit's lecture has been met out very, very clearly. At 20 to 26 weeks, again, if it is more than 21 weeks, excellent, more than 45% has put in. And when you have the first scan, let's say when the patient comes to you only at 20 to 22 weeks and no previous scans available, always call back the patient after second week to assess the EDD perfectly. It is important, right? It is important. Now, in the first trimester, yes, it is 1 week. If it is less, if the difference between the ultrasound gestational age and the LMP gestation is less than 1 week, do not reassign. If it's more than 1 week, assign the scan EDD. 14 to 20 weeks, it's 7 to 10 days. After 21 to 26 weeks, it's always 14 days. So if you have a difference of more than 14 days, more than or less than 14 days, more than 14 days, that you have to reassign the EDD. That is, you have to correct the EDD. But remember, if there is a scan done at 14 weeks or 12 weeks and the EDD has been assigned, do not change the EDD. So dating beyond 26 weeks is preferably avoided. It's very important. If you want to date and the patient comes to you for the first time, always 2 scans, 2 weeks apart, assign the EDD. Do not use only one measurement. Suppose if you are not very sure after 20 weeks, do not use only HC. Do not use only AC. Always use HC, AC, BPD, and FL, composite measurement, and you take the analysis. So after fixing the gestational age, do not change the dates in the subsequent scans. Do not use machine-related data blindly. Now, this is another scenario. A case of 40 years, mother got donor oocyte from 25 years. Now, which you have to take, which age you have to take is important. So now when you are assessing the abnormality, it is always to take up the 25-year-old male. So when you go for the first trimester, it's always important to assess the age of the donor. Coming on to the other question, which is the best method to assign the EDD? 58% have told you right. It is ultrasound. There are a lot of studies comparing the LMPs and the USGs, but it has been culminated that if first trimester, second trimester, or the mid-second trimester, ultrasound is the best modality to assess assign the EDD. So here is a case, a primey, 33 years. First trimester is completely normal and corresponding to gestational age. BP is normal, low risk pregnancy, hemoglobin is fine. Second trimester anomaly scan is perfectly fine. So this is what we are getting, a BPD, a 64 millimeter measurement, and you have 26 weeks, HC25, everything is fine. Now, is this enough was the question. So the fifth question was, what else you need? Do you need the estimated fetal weight? Do you need the percentiles, or you need the charts? So in all the cases, you need all the three. You need the estimated fetal weight, you need the percentiles of the estimated fetal weight, BPD, HC, AC, and FL, and you also need to have the charts. Now, charts, when can you have? When you have the previous report available, you can provide a chart. You know what, that's what I'm saying. The growth you are not measuring the size of the baby. By comparing just the size of the baby between two different scans is important, not a single measurement. So that was a question. What else you need? We require the estimated fetal weight, we require the percentiles of the estimated fetal weight and the measurements, and you need the charts. So this is what we are talking. Gestational age, or in that point, the size is how old are you or how much you weigh. But whereas in growth is how much you have grown from the previous scan. So that is important. So now in this case, again, you could see here, you've got the centiles. All things fall below second centile. This is what happens. This is what previously described as symmetrical IUGR. So this is what being described as symmetrical IUGR. But now it is early onset IUGR. Early onset IUGR. See, the important point to note, there was one question in the poll, if you could take it up, the FL. We say the FL was the last to fall, but many a times you have seen FL, the skeletal growth of the baby falls. But there is one thing which doesn't fall much is the foot length. So the foot length of the baby is the one which does not fall till late, even in skeletal dysplasia or in cases of severe IUGR, the foot length is the late to fall. Whereas femur length can decrease in cases of IUGR even before AC, if it happens much earlier. That is the very early onset FGR. So when you have a very early onset FGR, let's say before 24 weeks, it is always essential to rule out aneuploidy, always essential to rule out uteroplacental insufficiencies. Number 3, fetal infections. So these 3 are the things that you need to rule out in cases of early onset FGR or early onset severe oligoamnios without any history of draining PV. So these are the 3. So you need to rule out aneuploidies, you need to rule out fetal infections, and you need to rule out severe uteroplacental insufficiency. The question is, if suppose, let's say, we are saying we have to start aspirin when we have uterine artery abnormality before 18th week. Why before 18 weeks? Because that is the point where the complete arterial spiral arterioles form, right? Now, when you have the baby at 22 weeks, patient only comes to you at that time, you do a uterine artery Doppler, you find it at 95th percentile. Now, it is important whether to start this patient on aspirin or not. The thing says, no, you need not start because it will not be beneficial. At the same time, think about it. It is not harmful. It's not contraindicated. And even if there is the slightest possible benefit of improving the baby, you can still start the patient on. So at this point, the patient has to be discussed with the liaised. For example, the clinician has to be informed, and we'll have to sit down with the clinicians, talk to the patient. There may not be benefit. If there is going to be benefit, it may be minimal, but it can be beneficial to the baby. It is not going to harm you. So the patient may be started there. So now, is it IUGR? Yes, this is IUGR, number 1, which is significant. And that was the 6th poll, and everyone have answered it. Any of the above? Yes. So you have the estimated fetal weight or the abdominal circumference, any of the things. So the criteria is less than 10th centile, but any of these two is less than 3rd centile, it directly classifies as FGR. Now, which is significant to suspect IUGR? This is what the question. So everyone has answered any of the above. So that is estimated fetal weight and AC. So you don't consider HC and AFL always. Suppose FL is low and AC is also low, you consider it to be a IUGR. But when FL is low, the important point is when FL is small, and if it falls below the 10th centile, always take measurements of all the other long bones. It's important. Always take the femur length to foot ratio. These two are important. When you have femur length is low, small, less than 10th percentile, always take the measurement of all the other bones, and always take measurement of foot length, and you calculate the femur to foot length, which cannot be below 0.8. Which cannot be below 0.8, right? The next thing that we have already discussed. Now, first is to get affected is the abdominal circumference, which we have discussed already, why it decreases. Next is the brain sparing and the aortic isthmus change. That's why the arterial changes. Now, the baby tries to keep the blood within the central circulation. So there is reversal of flow in the aortic isthmus, and your middle cerebral artery shows increased diastolic flow. Then initially there can be slightly larger head. Why this larger head is because the abdominal circumference to aortic head ratio will be low. That is, the head will appear to be larger because the abdomen is very low. So the baby will appear to have as if a larger head. It's not a large head. It is comparatively large to the abdomen. So do we need any other parameter? Yes, we have the weight here. Weight also falls less than 23rd. Weight also falls less than the second centile. Now AFI is 14. Now this AFI, as I told you, in this case it is 14, but there are cases where it can be 7, 6, 5 at this any point. But AFI is only the response to the fetus to the ongoing pathophysiology. It's a response, the sequel, and it's not primarily a disease. Oligoamnios is primarily not a disease in case of IUGR. It's a response to the abnormality. This I think everyone has got right. So which is the best? Oh no, okay. Any of the above, yes. So you can have 4-quadrant single vertical pocket, but I preferably use 4-quadrant. It's easy, reproducible, and you measure all the 4 quadrants. It's as simple as that. So you have 8 as the basic line. So you just keep it 8 as the basic line. But remember, after about 34 weeks, you can have 7.5 and 8 with normal Dopplers. It means it is normal. So there can be a reduction in the AFI. This was beautifully discussed by Dr. Shilpa that day in the webinar, where there can be a decrease in the AFI as you go later in the pregnancy. Now, the important point which we discussed earlier, when there is an early onset FGR, it is always important to differentiate infection. We thought about genetics and also APLA, that is antiphospholipid antibodies. Number 4, uteroplacental insufficiency. Now these 4, again, we are adding one more. So infection, genetics, APLA syndrome, and your uteroplacental insufficiency. So these things can presume or can present as early onset FGR. So what next? So the next is Doppler. So Doppler is very important. What are the vessels? Now, do we have cutoff values for the vessels? Now, what do we have to remember is you don't have any cutoff values. We have percentiles. So the percentiles is very, very important. We need to evaluate the percentiles. Now, uterine artery, more than 95th percentile. MCAPI cannot be less than 5th percentile. Your CPR cannot be below the 5th percentile, right? Ductus venosus cannot be more than 95th percentile. Aorta, don't worry about the PI, cannot have reversal of flow, cannot have any flow below the baseline. These are the 5 vessels. These are the 5 important things. So uterine artery, PI cannot be more than 95th percentile. So uterine artery more than 95th percentile or umbilical artery more than 95th percentile is abnormal. Umbilical artery cannot have reversal of flow or below the baseline. Okay, 95th percentile, that's done. MCAPI cannot be less than 5th percentile. CPR cannot be less than 5th percentile. Ductus venosus cannot be more than 95th percentile, or A wave cannot be below the baseline. 5th thing is aortic isthmus cannot have any flow below the baseline. That's all. This is what we need to evaluate. So this was the value. So you could see the umbilical artery, it's about 1.1, and the 5th centile is 0.8, 95th is 1.39, so it's normal. MCAPI is normal, CPR is 1.9, so it is normal here. So see at 32 weeks, what happens? Again, it's within normal limits, PI within normal limits, CPR within normal limits. Now there is a question. The CPR falls, PPR starts to fall. The umbilical artery still, so you could see here, there is it's 1.7, 95th percentile is 1.2, so it's above 95th percentile. So MCAPI is less than 5th percentile. So when the MCAPI falls, automatically CPR falls, because MCAPI is a numerator, umbilical artery is a denominator. So it's like how the baby responds to the placental disease. So placenta comes down, you assess the fetal response. So that is what is CPR. So CPR is less than 0.7. So this is abnormal. Now what do? Do we deliver? No, we look for ductus venosus. Because this comes under stage 1, then we go for ductus. If the ductus shows reversal, then we go in for delivery. So reversal of flow in the aortic isthmus, which we discussed earlier. Now coming on to NST, that is a non-stress test and the biophysical profile. So the Doppler changes in IUGR precedes 3 to 4 weeks or even 4 weeks to 5 weeks earlier than your biophysical profile and non-stress test. That is the cardiac tochogram. So you need to assess, make sure that you evaluate the fetus with Doppler is very important. Now, this case, once you've known that baby has already gone to stage 2, it is important to put the patient on steroid. Now, perinatologists will require to have at least a baby, which is at least about 900 to 1100 grams. That's what they prefer. So but now today, the advancement of the perinatology evaluation and the management, now even at about 600 to 700 grams, they're able to get a baby alive. So remember, so management protocol is very important. Our role is to say the ages, stage 1, 2, 3, 4. Which stage are you going to deliver? Put the patient on steroid and deliver. Steroid is for lung maturity, remember. And you need to evaluate whether you are going to deliver a premature baby or a sick baby. Sometimes you need to strike a balance to a premature baby than a very sick baby, because if too much decompensation occurs intrauterine, you might lose the neurological intactness of the baby. That takes us to the 9th question, early onset IUGR, which is, 8th question, decrease in femur length. Is it a marker? Yes. Yes. Many of you have said no, but yes, it can be a marker of IUGR. Remember that. So when you have a femur length which is reduced, make sure you evaluate the foot length, make sure you evaluate all the long bones, make sure there is no other abnormality, and make sure the liquor and the uteroplasmal circulation is fine, and also evaluate the chest circumference. Now, chest circumference to head circumference cannot be less than 0.8. Foot length to femur length cannot be less than 0.8. So if the chest circumference to head circumference is less than 0.8, it indicates thorax is narrow. The baby will have severe respiratory compromise. It may be a lethal or a non-lethal skeletal, it may be a lethal skeletal dysplasia. That's what we are concentrating. So when the chest circumference is normal, when you are evaluating a case of non-lethal skeletal dysplasias, always have back of your mind that this may be a IUGR with low growth potential. So it is true that this can be a marker for IUGR. Poll 9, early onset IUGR, which is false. So it is, yes, chronic hypoxia, fetus adapts well. That's what we know about it. Associated with PE, poor tolerance. Yes, poor tolerance is false, because baby adapts very, very beautifully, and it has a very good tolerance to abnormalities. Final question is about late onset IUGR, which is false. So we had mild placental disease. Yes, true. Poor fetal adaptation. True. Umbilical artery is abnormal, which is false. Yes, because umbilical artery in late onset IUGR may be normal. CPR is mandatory in all cases. Yes. So that is what we were discussing. So these are the important points that you need to analyze. Now we have taken one case and we have put all the causes, all the possible scenarios, and all the possible things into this. I'm not confusing you with more cases. You need to assess this. I can put you, like, say 10 cases. I have 10 to 15 different cases to you. But this one case is an evaluation to say you need to evaluate a case of FGR serially. So now the question comes, when do we have to do the scans? When there is a low risk case, it is important to do a dating scan, followed up with a NT scan, an anomaly scan, and a scan between 30 and 32 weeks is very, very essential. If everything is fine, go ahead with the 36 weeks. So the patient goes in for 5 scans in her partum period. So these are important. When you have a 28-week scan, when it is abnormal, follow up accordingly. Similarly, when you have a scan at 24 weeks suddenly, and you have a decreased fetal movements, or when you have a decreased growth potential, follow up serially according to the stages. So now anywhere, put the stages into place and evaluate it properly. So that is what is important. So again, remember, our aim is to deliver not only a healthy baby, a neurologically intact baby, for it to fight this difficult world. Thank you. Thanks for
Thank you.
answering the polls, and almost more than 60, or average of about 60% have answered right. More than 60% have answered all the 9 questions right.
Okay, that's a wonderful feedback in the sense more than 60% have got the concepts right. So Bhavharan, congratulations for that, and we should congratulate Dr. Gulab and as well as Dr. Lalit Sharma sir also for this session, because this FGR session that comprising of 2 parts that has gone well with the viewers. That is the result of 60% correct is a reflection of that. So the questions, we have got the question answer session here. Am I audible?
Yes, sir.
Yeah, okay. One of the, can you please explain the criteria for SGA and FGR once again?
Okay. See, first thing, estimated fetal weight or abdominal circumference less than 10 centile. Now, this classifies as SGA or FGR. Now, when you have a baby between 3rd and 10th centile and you have Doppler abnormalities, you classify this as FGR. When SGA is there between 3rd to 10th centile, you don't have Doppler abnormalities, just put it as SGA and follow it up after 2 weeks. If the weight is 3rd centile, you directly classify this into FGR. The weight is less than 3rd centile, you directly classify this into FGR. So this is what the basic classification is all about.
Okay. So a few questions that I'm consolidated and I'm asking you regarding, in our country, most of the time, the 3rd trimester pregnancy scans, the indications are either a biophysical profile, Likert assessment, or for the placenta, or a growth assessment with biometry alone. So whatever you have explained, how can we convince our obstetricians to integrate Doppler and evaluate the Doppler? So what are the points in favor of that? How can we make out this transition from the existing indications to the Doppler-based management?
See, 2 things. One is to educate your referring physician, saying that Doppler is essential. Number 2, if they feel like you're going to get, let's say, charged more money for, let's say you put a separate column for Doppler and charge money, consolidate your charges, start doing Dopplers in all cases, whether asked for or not. So that's what is it. Whether it is asked for or not is not. See, you're doing the scan, you're interpreting the scan, and you're going to tell the scan. When you're doing biometry, if they ask for biometry, if the Likert is low, are you going to measure or not? Yes, we are going to measure the Likert, and we are going to say the Likert is abnormal, Likert is normal, or Likert is excess. Similarly, Doppler is just one button away. If you start doing Dopplers, it's going to take hardly, believe me, it's going to take only 3 to 4 minutes for you to finish the entire Dopplers. Maximum 3 minutes if you are very fast. And that can change a lot of scenarios. Do it for 2-3 months to 6 months. Automatically, the understanding changes, and also you do more number of cases, you pick up more number of cases, ask them to deliver. Sometimes they won't deliver, they might wait, they might feel, oh, this baby should have been delivered when this radiologist has told me earlier. So that kind of scenario you have to create. There's nothing like what they asked for, I do. For example, when the patient comes to you for a first time seizures at 45 years for an MR, it is essential for you to do a contrast study, whether it's asked for or not, because it is essential, let's say. Similarly, here, Doppler is essential. You'll have to do it. So when somebody asks for a carotid Doppler, you say, I'll do only Dopplers, I'll not measure the IMT. No, you have to do it a composite way. That's a comprehensive way of doing scans. You will have to integrate it. Don't separate it. Start giving reports in Dopplers. Start interpreting Dopplers. Tell your clinic physicians. They'll come back. Slowly, that teaching has to come. By cases that will come, they will start referring you for thing. Now, don't worry about what the requisition comes. At 32 weeks, if you have a scan, do a Doppler. Simple. Do a Doppler. It'll help you immensely. You can do it much faster. You will be quicker. You know what normal is, what abnormal is just by the waveform. That's what I believe. So I still believe at the 3rd trimester, after 28 weeks, if I do a scan without Doppler, it is incomplete. My scan is incomplete.
So in continuum to that question, there are a few questions on how will we report this, or the biometry, the Doppler percentiles, and finally the impression part of it. How do we give that report? Because do we have some kind of a uniformity in reporting?
Okay. See, the ICMR is coming up with the uniformity on the guideline part of it. We are working on it. It will come to you maybe in another 3 to 6 months down the line. We are working on it. We'll make the guidelines in certain ways and we'll get it to you. But see, fetal weight, abdominal circumference, and the Doppler findings, as I told you, you just have to integrate into the stages. If you have FGR, if it is normal growth potential baby, normal Dopplers, report it as normal. See, in 3 important points: the growth, the Dopplers, the Leica, movement. These are the 4 things that we are going to give in the report. So now these 4 things, anything changes, apply it. If that's going to be an FGR, integrate it and give it into stages.
So here is a question from Mukesh Gupta. A patient with normal scan up to 20 weeks came at 28 weeks of gestation, and on USG it came to be 9th percentile. At that time, it was labeled as SGA patient, came again at 33 weeks with 2nd percentile and fetoplacental Doppler normal. Then what should we diagnose it? Is it FGR?
Yes, it is FGR. Yes, because it directly falls under estimated fetal weight of less than 3rd percentile. Now, in this all cases, you are lucky that you have evaluated at 28 weeks and at 33 weeks, it has only been at stage 1. Lucky. Okay, but sometimes baby may deteriorate very fast. So when you have an SGA, make sure you follow it up at least after 2 weeks.
Yeah, right. There is an interesting question. How will you measure the uterine artery in a unicornuate uterus?
I think this question was asked before, and in unicornuate uterus, it is same. You have to take both the uterine arteries, and see the in unicornuate uterus doesn't mean the uterine artery is a hypoplastic or aplastic. Both the uterine arteries are going to be there. It's only the horn of the uterus, one side of the uterus is going to be abnormal. So you need to do both side uterine arteries, and then only you'll have to do it.
Okay, fine. So there is one question from Vijay Lakshmi Naik. What happens if you try Doppler in all healthy, appropriately grown babies?
You get the values. You get the normal values. So you know what normalcy is. Nothing happens.
But
let us see the evacuation effect. Let's see. The problem with the Western literature is like you have more emphasis on the damages, not on the good effects. See, honestly, that's what's happening with the mammograms and all those stuffs. See, the problem is they're all concerned with the radiation and all concerned with the heat evacuation that's going to happen in the baby. Let me tell you, if you're going to do Doppler in a single place for 30 minutes, it's going to increase the heat and cause evacuation. You're not going to do Doppler for 30 minutes. Let's be very clear. If you're going to do Doppler for 30 minutes in a single point, that to a power Doppler with a high velocity, with high PRF, it's going to increase the focal heat values and it's going to increase. The other important thing that we need, when the Leica is good, when you're doing a Doppler for umbilical artery, as Gulab already pointed out, if you do it 3 or 4 times also, it's not going to increase the heat much because the amniotic fluid acts as a very, very good cooler barrier. So if you do Doppler at a single point for 30 minutes of power Doppler, it's going to cause severe heat evacuation. The ALARA is not abnormal. ALARA is not too abnormal.
Yeah, and I would like to add. Yeah, tell me. Tell Gulab, please.
Yeah, actually, we are actually currently at Samrakshan doing this study where we actually do routine color Dopplers in the fetal weight of 10th to 50th percentile. So those fall within the normal range. So that is that is indicated to pick up those small abnormalities even in those 11th to 50th percentile range, so that even we don't miss those.
Yeah. The point is, even if the estimated fetal weight is more than 10th percentile, there can be a subset of category of patients with abnormal Dopplers. That exactly indicates those babies which has got a reduced velocity of growth. And we have seen a pretty good number in the 10 to 50th percentile in the Samrakshan series. So that has probably been not included in the classification that has already been given by the Greater Coast team. Maybe in the years to come, with the inputs from different parts of our country, we may be able to come out with a with an added classification of this estimated fetal weight between 10 to 50% with abnormal Dopplers is a subset category that has to be monitored and timed and followed up and subsequently delivered at the right and the appropriate time. There is a interesting question that most of you presenters have got a high-end equipment with good this thing. So what will we do from when in tier 2 centers or rural areas or suburban areas where our equipments are not good enough, or not having the same quality as you are having? So what are the basic parameters that you are that are necessary for Doppler evaluation in those setups?
Okay. See, whatever the machine you have, see, I've got 4 different machines, and we have different settings. Sometimes one is not working. We generally do it in the only thing is call your application specialist and set the values. See, that is very important. You need to have a technical person next to you and set the good 2D and your Doppler parameters. See, let me tell you, everybody says you have to do echo in only a high-end machine, Doppler only in a high-end machine. I don't know what that high-end machine classifies to. There are basic machines. Initially, when we started, we started with low-end machines, and Mindray started with, let's say, they had the DC6, DC7. Now they have huge machines. Now they have fantastic machines which can actually put into one-touch cardiac. Now, one-touch cardiac, everything is there where you can go and upgrade. But the basic thing is to have a good application specialist sit down with you and set the values. See, everything is that only. Once you tame your machines, it actually gives you very, very good results. The only thing is sit with your application specialist, let's say for 4 or 5 days. I'll tell you honestly, 4 or 5 days, you'll have to call them, sit with them, and then slowly ask them to set every value so that you become very comfortable. See, it's not difficult to do Dopplers in low-end machines. Let's be very clear. See, for my fetal interventions, I still use a low-end machine. I cannot take my high-end machine to the theater every time. So my theater always has a single machine, a separate low-end machine in which I do my fetal intervention. It's not like you cannot do it. The only thing is you have to get used to it, and your eyes has to be trained for it. For this. Now that high-end machine has come, we are thinking about high-end machine. We need 128 slice CT only to diagnose a brain infarct. We also have a single slice to have it. So similarly, it's like application specialist has to come in, sit with them, slowly evaluate, and then set the settings of your liking. You will get beautiful waveforms. I tell you, much better than me. You can, or anybody who are talking, you can get much better waveforms than any of us.
Okay, thank you, Bhavharan. So that question, basically you need to sit for Dopplers. I think the entry barriers are relatively low. It is not that high. You don't, most of the machines have got a very good Doppler. Only thing is you need to adjust the presets along with sitting with your application specialist and get it according to you. So Gulab, there is a question for you. What are the common pitfalls? Can you please repeat it? What are the common pitfalls for each and every vessel that you already described? Common pitfalls that you come across.
Yeah. So first, coming to the uterine arteries. So it is very important to look at the anatomy. The anatomy of the uterine artery is very important, and the location. So you have to image it right. I have seen many scan reports where they image the external uterine, the external iliac artery, and misinterpret the Doppler findings. So very important that the crossing of the uterine artery to the external iliac vessel is seen. Okay, you may not get in one plane. You may not get that in one plane, but you have to make sure that you have seen it. Okay, you have seen the external iliac, and even in the next section you can see the uterines. You have to image it here. Okay, so that is important to image the right vessel. In case of advanced gestation, sometimes you can actually even take the umbilical cord loop, which is lying close to your scan area. You can even take it, thinking it to be a uterine artery. So that is mainly to the uterine arteries. Then we come to the umbilical arteries. Umbilical artery mainly you have to take from the free loop. Okay, so that is important to create an average. And in those pitfalls, you have to remember the importance of the fetal breathing. So there are episodes of fetal breathing going on, and if you image in between those periods, so you may get this abnormal waveforms. So that is very important. You don't apply the PI centiles and the PI spectrum on those waveforms. You wait till you get a till you get a uniform at least 3 to 5 waveforms. So my staff even gets irritated when I say that this patient, this third trimester patient, has to wait once again. They are usually trained only for the anomaly scans. Only for the anomaly scans we ask the patient to wait again. But when I ask my patient to wait for the third trimester, my staff also gets sort of surprised. Why is asking a third trimester patient, which should have been finished right till now? So you have to wait till you get the readings in a state of apnea. So apnea is applies for any Doppler vessels. Then if you kind of get this waveforms which are actually there are absent waveforms in between. So they are usually due to hiccups. So this is sort of completes the umbilical. When you come to the MCA, very important, don't apply the transducer pressure, don't apply it. And the more you apply it, it will actually take off the diastolic flow. So suppose you have a fetus with brain sparing, which is showing you a good diastolic flow, and you have applied the pressure and you have made it low. So misinterpreting it as normal. Then coming to the aortic isthmus. So aortic isthmus, this site is very important. So it is very difficult in some situations where you can't even get this longitudinal view. In those cases, this axial view helps. And it is important to point the Doppler after the origin of the left subclavian artery. So if you point it before, you may again get misinterpreting results. Ductus venosus, the anatomy is important. So the anatomy, you have to locate, to zoom it up, see the aliasing, and place the calipers right on there. If you sort of you don't know what is happening, you just try to put one spectrum, you will actually most likely end up putting in an IVC or an hepatic vein. So that is going to create a hell lot of confusion for you. And in the umbilical vein, it is you don't image it usually because by the time you have found abnormality in umbilical vein, then it is already very late. So umbilical vein also, you don't misinterpret this small pulsatile forms as directly abnormal. You take into account all the factors which you have seen in the previous term.
Okay, thanks, Gulab, for that. Bhavaharan, there is a question. Do we routinely do Doppler for all the 5 vessels, or just umbilical artery and MC and uterine artery is enough? Yes. And as a sequel to that question, let me, should we use automatic measurement or manual for the spectrum?
Okay. See, if you have a uterine umbilical artery and the MCA is normal, just stop with that. You need not go ahead. So when you have uterine artery or the umbilical artery which is abnormal, always go for the MCAPI, calculate the CPR, and also do a aortic isthmus and ductus venosus to see if it is normal. So if any of the vessels is normal, always do all the vessels. If the uterine artery, umbilical artery, MCA is normal, you can stop with that. Coming on to the automatic and manual measurements, see, the automatic measurements, the manual measurement is that you'll have to be very precise on your tracings, that's all. Otherwise, you can use your automatic measurements. If your waveform is good, and if your pulse Doppler gives you a good waveform, bright waveform, not mixing of waveform with other vessels, it's always good. As Dr. Gulab beautifully showed, when you apply two different, when you apply a caliper between 2 vessels, when 2 umbilical artery crossings, or sometimes you might get an improper waveform. You can get double peak. You might mistake it to be a arrhythmia or something like that. So that is important. Where you measure is important, and either automated or manual, both are good. If you have time, always manual. But if you have an automated measurement, which is very fine, you can use an automated measurement. But whether you have to do all vessels. If uterine artery, umbilical artery, and the MCA is normal, you need not do the ductus venosus and aortic isthmus.
Yeah. There are a few questions on the estimated fetal weight and growth charts. This is another Pandora's box that has to be opened up. Maybe another series we may have to do on that. So estimated fetal weight, by which formula do you recommend? Hadlock 3 or Hadlock 4? And which growth chart, Hadlock or any one? And so that, shall we use Hadlock so that we will have uniformity all over India? So what is your recommendations on that?
There are many charts. Many charts. It's up to you to decide, and it's important that in our point we use Hadlock 3, right, sir?
Yeah.
We use Hadlock 3 in we use Hadlock 3, and that's what we uniformly started to use. There are many different charts. The only thing is how to measure. For Hadlock, BPD has to measure from outer to inner. There is one other chart, Liley, which you have to measure your BPD from outer to outer. The only thing is how do you measure and how do you maintain is very important. And always use a similar chart. don't skip the charts. There cannot be one chart which is better than the other. The only thing is it is important that we need to form we need to have a uniformity in our measurement every time. That is important. So we need to have uniformity in measurement. So we generally use Hadlock 3 for measurements, and the calculators like FMF calculator, we use it for the first trimester, and for the third trimester, if need be, we can put it into the Barcelona, which is almost nearly equal to what the Hadlock 3 gives us.
So the point is we have had quite a bit of discussion, debates and research on this particular subject for quite some time. And what we have realized is that the methodologies for calculating the estimated fetal weight, the different formulas, and even the growth chart percentile calculations, the sample sizes that has been taken, all these are different. And there is a range of errors that can happen, or the range of difference that can be from 6 to 23%. So there is nothing called a ideal growth chart or ideal formula. But as of now, what we have seen is Hadlock 3 is widely used and goes well for the estimated fetal weight. But as far as the growth charts are concerned, Hadlock or Intergrowth has got, there is a little bit of ambiguity on which one has to be chosen. But Hadlock seems to be the chosen one by majority, and Samrakshan also has adopted a Hadlock for the time being.
That's what the important point is. When you use Hadlock 3 at 25th, 24th week, always use the same chart at 28 weeks so that you can assess the interval growth. Don't use different charts for different babies. Always stick to one chart so that you know the growth potential. The weight may be, let's say, plus or minus 100 or 200 grams. That is different. But as I told you, the growth chart, the growth velocity or the growth potential of the baby is important. For this baby, for this mother, weighing so much at 24 weeks should have grown this much at 28 weeks. So that is what the growth potential is all about. So that is what is important.
Okay, so Bhavharan, the final question, what is the role of Doppler in every trimester of pregnancy? Do you recommend Dopplers in all trimesters of pregnancy? If so, what is their role? That's a final question, because more questions are there. Maybe we may have more sessions on FGRs and case-based discussions also. But as of now, this is the second part of the mini series ends here. But Bhavharan, can you answer that question? What is the role of Doppler in every trimester?
In the first trimester, while doing an NT scan, two things. I always do a Doctor's venosus. I always do a uterine artery. When the patient comes in for an anomaly scan at about 20 to 22 weeks, I always do a uterine artery Doppler. Always. When the patient comes in for a third trimester, always I do a uterine artery Doppler, umbilical arch Doppler, and MCA. If these three are normal, I stop with that. And growth is fine, everything is fine, we stop with that. If anything abnormal here, then we go evaluate the ductus venosus and the aortic stenosis. So let's say to start with, when you're asking these questions, you're thinking that will it consume more time? And once you start, yes, it will consume a bit of time. But once you start doing it regularly, in about a year, you will see the difference. You will finish in about another extra 2.5 to 3 minutes. Am I right, Gulab? That's what it is. If everything is fine, you can finish it with about 3 minutes. So once you start doing it only, you will know how easy it is to do Doppler. Till you start, everything has a hurdle. Once you start, you'll know how easy it is to do a Doppler. Every baby gives you a different response. It'll be very interesting. See, literally in your mind, you can talk with the baby. Hey, you're not showing me your Doppler. You're not showing me your ductus venosus. Hey, baby, come on, turn. Now, okay, you're turning. Now, every baby will respond some way. And there will be like MCA will be abnormal in the baby. MCA will be normal in the baby. You think a lot when you actually do obstetrics. It's really interesting. When you start doing it, you will just fall into the honey trap. Once you fall into the honey trap, there is no way that you can come up. You will always be in the honey trap immersed. Every baby will teach you a story.
So with that note, that means you should not just listen to the fetus, you should also talk to the fetus for that is the message that Bhavharan wants to convey to everyone. Thank you, Dr. Bhavharan and Dr. Gulab Charja, for those wonderful sessions, and we had quite a bit of questions here. I have tried to include many of them, but there are still more. But due to time constraints, we will have to stop it here. One thing that I've understood is we need more and more sessions on fetal growth restriction and into the nitty-gritty of all these things. So thank you very much, speakers. Thank you very much, Mindray, for supporting us, powering us. And thank you, KREST Kochi, IRIA Kochi, and the office bearers, President Professor Dr. M.R. Balachandran Nair, Secretary Dr. Ramesh Shenai, Dr. Praveen Nirmalan, Dr. Amal Anthony, Dr. Rajesh Kannan, and the entire team here at Cochin. And also, I would like to say special thanks to the Samrakshan core team, the webinar speakers from different parts of the country, and also to Dr. Ramesh Shenai who is in charge of the technical and the campaign committee, and Dr. Praveen Nirmalan, who is in charge of the research and analysis and the publications division. So once again, thank you all. And this has been a wonderful session. I wish to thank all of you who have expressed their appreciation about this program, especially the last program. We have received so much of congratulatory messages on the talks of Dr. Lalit sir, Dr. Bavaharan, and already Dr. Gulab Chajar. I've seen so many congratulatory messages for you from the different parts of the country. So this series has been a well-noted one, and maybe we'll continue with the preeclampsia series and another series on fetal growth restriction, more focused on the Samrakshan form submission, because that is where the focus is. Because more and more people has to submit the forms, then only the research in India can be well established. We can analyze it, we can have our own data. That why I'm again emphasizing on that particular point is the data that we have is enormous. I've seen the EuroCat study on congenital anomalies that has been the number of pregnancies that has been taken in that is from 2000 to 2010 is just 1 crore. But in India, every year we have got 2.7 crores of live births. So you can understand, if we are really putting our effort to document this data, the amount of information and the insights that we are going to develop is tremendous. And it will really be a boon to this nation. We will be not only reducing the perinatal mortality, we will be contributing to the healthy new generation of India. With that note, thank you very much for all those who have joined. Thank you, the speakers. Thank you, Mindray. Over to you, Arumugam.
Interesting, sir. Hi all, this is Arumugam Balasubramanian again from Mindray team. Those were really insightful and exhaustive clinical sessions by our beloved speakers. We could see the success of this webinar by active and successful participation from audience. Our sincere thanks to our speakers, Dr. Bavagaran and Dr. Gulab. Thank you, sirs. Also, we are grateful and thankful to Dr. Rijo Matthew for his motivation and support to us. We Mindray India team is very happy and thankful to join hands with IRIA Kochi and KREST Kochi for Samrakshan webinars. Thanks all delegates for your continuous participation. Mindray is happy to spread the flame of knowledge throughout India. Thank you all again. Good night. Jai Hind.
Good night.
Thank you.
Thank you. Good night.